Thank you, Dr. Thomas. I think in the interest of time, I'm going to move on and ask Karen Louie to turn on her camera. Karen has a BSN and a master's degree in exercise physiology from the University of Wisconsin, and she has directed hospital-based and physician-based cardiac programs for 25 years. She has served on the AACVPR Board of Directors for 12 years, including being a president. Since 2006, Karen has been a legislative regulatory analyst for AACVPR. This current role involves working with CMS and Congress on cardiopulmonary rehabilitation coverage policies and legislation. We know that legislation can have a significant impact on our day-to-day practice. Further, with CMS regulation, things for me get quite complex. I am hopeful that Ms. Louie can distill some of these policies and regulations down for us and share where there may be some more opportunities for advocacy.
Great, thanks. Thank you for the invitation to be part of this. It's really an honor just to have learned from many of those names mentioned here, speakers today, and those continuing to lead us in the science and the practice, because they both go hand in hand. I know I learned from working in cardiac rehab for many years, it required a patience in helping our patients make changes. Didn't happen overnight. And it turns out, after now a number of years in the advocacy space, it also takes patience. It might be a better word to say perseverance, but at any rate, somebody's got to do it. So I will take my perspective over the next 30 minutes to share with you. Let's see. I have no disclosures. Very briefly, I do want to acknowledge that there is a difference between Medicare, CMS, Centers for Medicare and Medicaid Services, and our commercial payers. Our current Medicare regulations are, a really confused reality of some constraints that are not practical, are arbitrary, and some opportunities. So I'm going to focus on more the opportunities that we can function with the rules that we have right now. And most importantly, sometimes you just got to get out there and go to the higher level. And so sometimes that just involves the ones who wrote the laws, the rules, Congress. So my focus will be on Medicare rules, not commercial or private. Some of the private payers choose to follow Medicare regulations, and some don't. But today, typically the mix is half and half, give or take a little depending on where you live. It's always important to know that patients' individual plan, because pre-authorization is often necessary so that you know what's covered for the patient and the patient knows, and they can plan and be prepared for length of time and what's covered and their copays, etc. And commercial coverage is sometimes ahead of Medicare, as in, I know a number of privates that would cover heart failure long before CMS came around to recognizing the value in 2014, and sometimes less inclusive, like old school, we don't cover non-ECG monitored. So all around it is requiring continued education of all of our payers. Roughly 90% of the programs currently are in a hospital outpatient setting. So that's what I'm going to focus on. And since March of 2020, none of us will forget that date, is when PHE came along and hospital outpatient services were given the option of providing virtual delivery of sessions. That was under the umbrella, and is under the umbrella of a term called Hospitals Without Walls waivers. That's how CMS was able to allow virtual services for hospitals. And I want to clarify here, the current definition of a virtual session in Medicare's eyes is that it must be real-time audio-video communications technology. It's billed by a hospital as if that care is furnished in the hospital, and there's a modifier to tag onto it, but it's not billable or delivered by a physician, and it's not considered telehealth by Medicare. And we've been told that, it's been in writing over and over. We cannot use that term telehealth in the hospital setting because CMS doesn't reimburse for hospital-based virtual cardiac rehab that doesn't meet the definition I've just walked you through today. So keep that in mind as we try to go forward. The PHE is now set to expire October 13th. Health and Human Services promises, that might be a strong word, a 60-day advance notice prior to any public health emergency expiration. They can't go beyond that. So if we don't hear in the next week and a half that HHS intends to expire the PHE, in all likelihood, it will be extended another 90 days. Now that puts it into January of 2023. And that will come into, keep that in your mind as we talk a little bit later about some of the PHE coverage regulations that have been proposed. So Medicare telehealth services, remember that it's telehealth services, have been extended 151 days, it's about 4 months, beyond the expiration of the PHE. So that gets it into 2023. And that was under the Consolidated Appropriations Act that was passed in March. The joint societies altogether, those who care about it are in the pulmonary and cardiac rehab space, sent a letter to CMS in January of 2022 needing some clarification on the difference between the physician setting and the hospital outpatient setting. We did get an answer from the Medicare administrator in April that made it clear that that 151-day extension, and maybe longer if a current bill that passed the House but hasn't passed the Senate goes, does not include the hospital outpatient walls without waivers that allow CMS to extend beyond the PHE. So let me say that one more time. Telehealth services are covered for 151 days beyond the PHE. There is a bill, HR 4040, which has passed the House, that would extend the telehealth services through 2024, but that is not in place. It's only passed the House, very convincingly supported and passed, would need to pass the Senate to be enacted. But in the hospital setting, waivers are done when the PHE is done. Now, CMS, again, extended physician office-based, that means owned, cardiac and intensive cardiac rehab. When I say cardiac, I do mean intensive with it, for virtual sessions through 2023. They took those cardiac and intensive cardiac rehab codes, put them in a category 3, which they are allowed to do on the premise that they want more evidence and data of safety and effectiveness. So that was great. If you want to see that in writing, it's in the Federal Register, volume 86, and there's the page number for you. Again, that definition is real time, audio, video, two-way communication. It's not a phone call, it's not audio only. However, also, CMS proposes in 2023 that the home will no longer be a delivery option for cardiac rehab in the physician-owned setting or in the hospital outpatient setting beyond the PHE. So it comes down to Congress needing to pass a law around telehealth and hospital virtual services. And that's kind of where we sit right now. It's changing almost weekly. Directly speaking about virtual direct supervision, that is allowed during the PHE and through the end of the year in which the PHE expires. Now that was wonderful wording, because what that does is it equates the physician setting and the hospital outpatient setting. So hospitals, if we roll into January of 2023, which is highly likely, my speculation only, we will be allowed to use virtual direct supervision through 2023. That definition is immediately available as it is prior to the PHE, using a virtual presence, which is audio and video together, two-way, real-time. Don't have to be in the same place, doesn't matter where the physician is, just have to be immediately available to be accessed. And that kind of puts them both on the same playing field. And I know that we'll be hearing a lot more about virtual delivery models as today goes on. But I'd really like to address our some of the Medicare rules used in a positive way. Let's turn it around. And this comes, and you would think Nancy and I might have coordinated, from the Cardiac Rehab Change Package and Barb. And that was put out by the CDC Million Hearts and the AACVPR, a collaboration that I think is just the guidebook for great ideas. And it broke how to improve cardiac rehab into 4 areas. I'm going to focus only on the enrollment and participation and adherence, but I've provided the link to the document itself. I think it's great as a team building, look at it together, see where your gaps are, pick one, say, this is a gap, let's try this, let's see if it works better. So that's how I think this tool should be used. And some of the CMS flexibilities, I want to point out, that are really for the patient, because when you read the change package, if you don't know the rules, you might think, oh, we can't do that because Medicare won't let us. But that has changed, not at rapid pace, but slowly. Like, for example, we know now that cardiac rehab does not have to be an exclusive service. It can blend with other services. That means using the same staff, space, same time, blending phase 2 and your maintenance together. All those things lead to more access, better efficiency of all those things. So that's absolutely something to consider, look at if you're juggling with sharing space with others. How can you do it perhaps more efficiently? The other rule is that the session duration must be at least 31 minutes to bill for one session, and 91 minutes or more if you're billing for 2 sessions in a day. Now, notice I'm careful to say session duration. CMS doesn't regulate exercise duration. I get that question a lot. Exercise is determined by the physician staff, the cardiac rehab team, based on that patient's individual need. Thank goodness they let us do our job. So the only caveat is there must be some exercise every day that the patient receives cardiac rehab. Some patients need a lot more education, perhaps, than exercise. And again, back to the individual, what do you focus on for that patient? What's best for them? Up to 2 cardiac rehab sessions a day are allowed. And to compare that, intensive cardiac rehab has up to 6 sessions a day. So I would propose that we are perhaps underutilizing this option. And so in the change package is one strategy called accelerated cardiac rehab, and that you can get more sessions perhaps for that patient. Average right now is 25. That's from Steve Katayan and some other data. But as Randy had pointed to, the more sessions a patient gets, the better the outcomes. And so we need to keep that in mind as we accelerate and try to give patients what they need and more of it, rather than a short term. It's hard to change exercise levels and behaviors in such a brief time, as we all know. The other advantage is, keep in mind, 1 copayment per day. I've had a lot report back to me that they don't get charged 2 copays for 2 sessions a day. So that's advantageous for the patient, particularly if they're coming from a long way, maybe doing a hybrid model. So it's to their benefit to, when you have them, keep them. Another way to apply this, use this 2 sessions per day flexibility, is high calorie expenditure exercise, which is, it's been out over a decade. Phil 80s, Pat Savage, and that group started using it. We all acknowledge that a high percentage of our patients are overweight. Weight loss is a goal. Over half have metabolic syndrome. And what they found was that longer duration, lower intensity in that program, more calories burned per week, was more effective compared to what patients typically get, 700 to 800 calories for standard, like 3 days a week. I know from a personal perspective, we also found that those patients who are low level and struggle to get a high intensity can very easily just stay on those machines longer, burn more calories. They absolutely do fine with that. And it's a good strategy to consider for some of your patients who might benefit from that. CMS doesn't put a limit anymore on the number of sessions per week. So one of the other strategies in that change package is the open gym model, which provides more opportunity for patients. It decreases wait time to get in. You have more slots open if it's 5 days a week, even if it's not 5 full days, more windows of time. You stagger starts that fits more people in. And by them signing up for when they want to come, you're teaching them that this is what it's going to be like when you graduate from here and go to a local gym or Y or wherever they intend to join. And you hope they join somewhere, make a commitment to continue their exercise after graduation. So it gets them into that pattern of behavior. And patients then have control over their exercise schedule. And I've got to tell you from a personal experience, they love that. They love having the control and the flexibility. Works very well. There are only 2 CPT codes for cardiac rehab, only 2. One is a code that has continuous ECG monitoring, exercise or education, although why you'd have them wear a monitor for exercise. However, some of the privates don't recognize 93797 for education. So I back up that statement. You may have to have them wear a monitor for some of the exercise. And the other code is for without an ECG monitor on for either exercise or education and counseling. Keep in mind that initial assessment, the term evaluation is nowhere in this. It's an assessment. It's part of that first billable exercise session. It's not billable any other way. Another FAQ that I get. The team provides the ongoing entries and contributions to these assessments and to the individual treatment plans. It's like a living map, isn't it? I would think that each day, certainly at least each week, you've conversed with the patient, you're engaging the patient and helping in this plan, reaching the goals. I'll come back to this in a little bit. So CMS does not require any ECG monitoring. Either code is acceptable, both are paid the same. And many cardiac rehab programs now are coming around to assessing what does this patient need? How stable are they electrophysiologically? How many sessions? Some programs just do maybe the first week of monitoring and then go right to non-monitored. We can now teach them how to use that Apple Watch or Garmin, whatever their technology is, for home use on the days they're not in the center-based program. And remember that self-efficacy is really enhanced when that ECG monitor comes off. I know I've heard many say, well, they won't feel safe. But Joe Carlson and Barry Franklin showed that back in 2010, 2000 probably. Long time ago, but it really is substantiated. And then your capacity isn't limited to the number of ECG monitors you have. It's only limited to the number of pieces of equipment that you have in your center, less wait time. Individual treatment plans must be reviewed and signed by a physician as it stands now, no later than every 30 days and through completion. Most programs are getting it signed about every 25, because if it's day 31, if you undergo an audit, CMS will deny it. Talk about rigid. However, I digress. The initial ITP must be reviewed and signed by a physician, patient's physician, medical director, a physician in the program prior to or on that first billable day. And this physician would only need to have knowledge of the patient. So it does not have to be a particular physician doing that. Now, what's new in 2022, I alluded to earlier, we've spent a lot of time reminding CMS that cardiac rehab is a global fee. So there is no physician, there's no professional component in a hospital outpatient cardiac rehab program. And yet we have medical directors who spend time, develop ITPs, review ITPs, sign them, come and, see patients who need it, but there's no physician payment to that. So CMS heard that, and what they've offered is, I think, like a bone. Now a physician may do an office visit with a patient coming into cardiac rehab, complete an ITP as part of that office visit. And the way that's billed is by that physician using an emergency management or E&M code. Now, this is only optional. And I think the point was sometimes a medical director is less inclined to be engaged if they're busy practice, they don't have a lot of time for it. Maybe this is a way to help financially allow them to maybe spend a little more time in cardiac rehab. And it's optional, doesn't have to happen. I've had a lot of hospital programs call me and say, how do we bill? And what E&M code do we bill? And I say, it's not you, it's not the hospital that bills. And it's the physician who decides the level of the emergency and management code, of which there are 4 or 5 levels. And that's on them to determine that. So kind of a nuance, but it's an option for those who think it might help your physician engagement in your programs. As far as ITPs and outcomes assessments, it is very clear that the staff and the physician work with the patient to set goals. And here's the quote from the CMS Coverage and Analysis Group that wrote this in 2009 when our current provision took effect. And in November of 2021, they reiterated this because there were some RAC recovery audit contractors who were denying if the physician did not literally do the assessments and the ITPs. Well, we all know it's a team, and I don't know many physicians that will sit there and have the time to administer a depression scale and a nutritional evaluation, etc. So clearly, anyway, bottom line, the RAC auditors now know that that was a misinterpretation on their part, and they've begun to give some redeterminations when it was that reason for denial. So I guess that was called a small win for the field. So these programmatic changes that improve cardiac rehab accessibility will reduce delay from the hospital and get them in sooner. We know that that's important. Sherry Grace and others have shown us that. Set that cardiac rehab date up prior to hospital discharge. That's another strategy in the change package. Group orientation, another strategy to get patients in quicker rather than one-to-one. They get a lot out of that. They almost bond in that group orientation, whether that's billed by an NP or someone in a clinic doing a focused a shared medical appointment. More likely it's your cardiac rehab staff, and you don't bill for it, but it moves things along and gets patients started, gets them in and engaged. Utilizing that virtual direct supervision flexibility while we have it has allowed programs who had closed, to open back up, rural places, critical access hospitals to open up and bring more patients in, even though there's not a doctor physically available. So it's been very beneficial in many settings to open the doors, to expand hours. Another strategy is using blood pressure measurement as you need to, not the old days of blood pressure on every machine, on every patient, every time. So there are algorithms to improve the efficiency of that aspect. And then the hybrid paradigm, which I hope we're here to hear a lot more about today, of center-based and virtual together, have really improved, got us through the PHE for patients who wouldn't have gotten anything. Here is a link to the revised current regulation for cardiac rehab. It hadn't changed since 2009, but all these revisions were worked in, and it's was published in the Federal Register in November, and you can have that as a resource. Finally, I would like to talk about the 2 bills. As I said, sometimes you just have to go to Congress to get something improved for your patients and your programs. So the Increasing Access to Quality Cardiac Rehab Act is moving along. All the bills right now have been pretty slow moving. It's not exactly a bipartisan environment up there. I'm sure most on this call will remember in 2018 when a bill was passed after 5 years of work to allow non-physician practitioners to provide direct supervision for the services. That does become effective 2024. However, this bill, spearheaded by American Heart Association, expanded that and could potentially allow non-physician practitioners to independently order, that would be an easy fix, to provide the direct supervision, perhaps to review and sign ITPs, and perhaps to serve as medical director. Those two are questionable because remember, if this passes from a bill into a law, then CMS takes that law and interprets what they believe it intended. Sometimes they get it right. Sometimes they interpret it differently than what we intended or how we would have interpreted it. So I'm not going to make any promises on what CMS's final interpretation on anything might be. A very important bill, very urgent bill, hand in hand with that one is Sustaining Outpatient Services Act. We've been working on this for 5 years. Since the Bipartisan Budget Act of 2015 was passed, what that did, it served a purpose for some of the services in the outpatient setting, but it was quite detrimental to cardiac and pulmonary rehab. This one would allow that payment equity for hospital outpatient cardiac rehab. The reimbursement would remain at that outpatient rate, not dependent on where that program is located. Currently, if it's off campus, it's about a 40% reduction in the hospital outpatient rate. That's a big hit because, as Randy had said, these are not high revenue services. They're beneficial, they're high value, but not the high-end revenue ones. Those small number of programs that were already off campus in 2015 were grandfathered. I'm already hearing from those programs saying, we're already out of room, we need to expand. And financially, they just can't. It's a hard sell to administration, especially in these times. So this bill will allow smaller services like cardiac pulmonary supervised exercise therapy to expand into that beautiful medical fitness facility, down the road, across town, out where the rural clinic is, where patients don't get in, where every state we know has those rehab deserts, even in the city. San Francisco has, it's 2, I don't think it's 3 anymore, cardiac rehab programs. That's ridiculous, and we know this. So we want to improve patient accessibility. Really, this bill is a technical fix of that BBA of 2015 that will allow program growth. So with that, I'll take a deep breath and take any questions.
Wow, Karen, that you went through a whole lot of information, and I think it's actually reflective in the Q&A. There's quite a few questions for you. What I'd like to do is that one theme several people have asked is looking at kind of the exercise intensity as a key factor in maintaining the health status of the patient. And you have talked about how it's very individual in your ITPs. And several people have asked, how do we have the data to support some of these, the variety of intensity of exercise program, and how can we look at it from a more global perspective?
My vision is now like payment and regs. So if what's being asked is someone who said, our patients gone from 2 to 5 METs, should we graduate them early? And I know Barbara Fagan answered the same question that I did this week. There are so many ways this patient can benefit, not just exercise. So why, if the patient's not eager to leave, go back to work, why wouldn't you want to keep them and continue to help them establish lifestyle changes beyond? So, and HIIT, we know that high intensity interval training is great and it's a standard of care. I've heard Ray Squires, and I believe anything Ray Squires says. So, and patients love that. So another example of, we work with each patient individually, and that's right. And there are some that might go from 2 mets to 3 mets, but by golly, they can get out there and they're coming, they do better, all the benefits. So I won't go on and on, but I might have missed the mark on that question, but you can tell I'm passionate about what.
No, that's great. And actually several people have asked in the quick Q&A whether there'll be a recording or whether we'll have access to slides. All of that will be sent to you post event today. So everyone doesn't need to worry about frantically note taking. You will have access to the lectures as well as the slides after the event today. And then the other thing, in the interest of time, I would like to take a 5-minute break so people can use the restroom, stretch, plank, whatever it is they'd like to do. So I think, Karen, there's a lot of other questions in the chat that we might be able to address during that break, if you have a chance.
Okay.
So on my clock today, it says 10:11 a.m. We'll actually come back at 10:15. So maybe a 4-minute break if everyone's okay with it. So I will see you everyone back at 10:15. And Karen, we can kind of turn our attention to some of the questions in the chat.
My name is Eldrin Lewis, and I'm the Chief of Cardiology for Cardiovascular Medicine. The Cardiovascular Medicine division at Stanford is tremendous. Not only can we manage the standard cardiovascular disease, we can actually manage mitral valve disease, aortic valve disease, and even tricuspid valve disease percutaneously. We have world-renowned cardiologists, cardiac surgeons, as well as staff, all who work together as a team so that we can provide cutting-edge, innovative cardiovascular interventions. We can take a patient's underlying genetic risk, understand the environment in which they exist, and then apply that to maximize outcomes. If you were to refer one of your patients to Stanford Health, you should expect that we're going to work together with you to maximize the health care of that patient. Your patients will have access not only to just what cardiovascular medicine can provide, but what all of Stanford Health can provide. And we have a lot of teams outside of the cardiovascular division to provide comprehensive care for patients who may have more than one disease. We want to make sure that we're giving your patient back to you so that they can continue to receive the outstanding care that you've been delivering longitudinally. We want to use technology so that we can communicate with you about all of the things that happened to improve the health of your patient. You don't necessarily have to have your patient come all the way here, but we can use virtual visits or even communications with you to try to answer a specific question. So we are poised to apply our research knowledge, our clinical expertise, and our innovation and technology to improve the patient care and to improve outcomes for all patients who come and see us.
several small steps you can take to reduce your risk of heart disease. Which step will you take today?
Okay, 10:15, actually 10:16, and we're back. We will start off this session with a panel of speakers talking about cardiac rehab across a variety of settings. To kick us off, I will ask Jonathan David to turn on his camera. He is well known to many of us for his dedication and passion in the field. He is part of our inpatient cardiac rehab team and has been the glue in helping today happen. I will let him go ahead and introduce his co-panelists as well. Thanks, Jonathan.
Thank you, Dr. Abba. And it has been a host of team. We work together. There'll be Julie Arbekel, who would follow my talk. It will be a recorded version. Followed by that is Robin Weddell, who has a cardiac rehab and a wellness center for the community here at Palo Alto. So I will begin my talk. Let me bring up my slides here. Do you see my full slides here?
Yep.
Excellent. All right. Well, I'm passionate about cardiac rehab, joining everyone else here. I have no disclosure. I'm tasked with who are the eligible patient populations, and what is the role of inpatient cardiac rehab, what's the pathway that happens there, and how does it yield itself to the transitional care processes, and what are the outcomes? Let's poll. Let's begin with the poll. Mario, could you help us with the poll? All right. This is in the inpatient setting. The first question, are eligible patients at your practice locations referred to outpatient cardiac rehabilitation before they discharge from the hospital? You have choices here: yes, no, not sure, or I do not practice as a hospital. Right. We'll give a couple more seconds. Could we proceed to the next question? Waiting for the next poll question. There, thank you. Referrals to the outpatient cardiac rehabilitations are automated. This again applies to the inpatient settings. If the referrals are automated, again, the options we have here is yes, no, not sure, or do not practice at the cardiac rehab locations. A final question. This is at the outpatient setting. If you were to work in a clinic, ambulatory setting, same-day surgery, yeah, here you want to see if it was being referred, if the referrals are being sent before they're discharged from the clinic. So it is a yes, no, not sure, or I do not practice at the hospital. Right. Right, we'll give a couple of seconds and then we could share the results. All right, we could end the poll. Excellent. We see about 70% for the referrals being sent before hospital discharge. That's great. That meets the helps with the Million Hearts Initiative. All right, very good. Next question. All right. And then for automated, we have about 38% of us automate the referrals. Excellent. Next. And I would say to excellent, there's still work to do, and 41% at the outpatient clinic. So we all have work to do. With that, I'll present my slides. We could end the poll. Thank you. Takes a little bit for the slide to pick up. There we did. Okay, we have two duties. One is to help, or at least do no harm, which we face that every day. All right, I'm going to unpack a set of B's that I'm going to go through in the next slides. With that, I welcome you to Stanford University campus and the hospital campus. Anytime you visit us, you will see this great landmarks. At Stanford, we have two settings. One is the inpatient setting and the outpatient. And outpatient clinics, ambulatory settings, same-day surgery. The inpatient settings has the inpatient cardiac rehabilitation team and the heart failure clinical nurse specialist. Out of the ambulatory settings, we have multiple clinics, cardiovascular clinics across the continuum. Here is our dedicated, cohesive team, bright people. Now, who is eligible for cardiac rehab? There are primary and secondary qualifying events. And there's anyone with acute myocardial infarction, someone who had a PCI, somebody who had a CABG, heart valve, sorry for the slides to be going, someone with a heart-lung transplant, someone with a stable angina, systolic heart failure. And there were questions in the chat. This diagnosis-based and a procedure-based, or someone with a ventricular assistive device or a biventricular pacemaker. So the delivery of cardiac rehabilitation in the acute care settings. The slides are trying to race before me. Pardon. Right, I will take it from where I left. Moderator, if you could tell me if I'm on the right screen when I reach that slide. Am I right here?
Yeah, you're on the slide that shows the care pathway, but then you're flipping back and forth between the qualifying events and the care pathway.
All right. Seems to have trouble with the slides. I'm going to use this direction so that I don't take much time here. So the care delivery, as you heard Dr. Thomas and Karen Louie mention, the care delivery for cardiac rehab happens right at the hospital. It happens at phase one, where the acute cardiac event happens. And that's where the inpatient cardiac rehabilitation, plays a great role in the acute care settings at the onset of an event. And it's a team-based approach because we know that not one team can do this. So it's together identifying who the patients are, engaging with them in an early stage, meet where the patient is, either a clinic, ED, recovery room, in a same-day surgery. Doesn't matter where the location is. But if teams are going to be based on, this is my location and we can't reach the other end, then we miss out opportunities to serve such patients. It's important that we include patients and families and the caregivers. Walk through give them a walkthrough, what the acute recovery entails. What are the goals of care each day or on each area that the patient might not know. So that way they are involved in making decisions, offering to the team. It's important the team gathers what are the determinants for their social health, what are their determinants for clinical outcomes. So these are important in kind of crafting a plan of care towards either helping them to go home or to a facility, or most importantly, the goals that we talked about, participating early in cardiac rehab to reap the benefits. So we have a host of teams that we collaborate with. I mean, I listed a list of folks we know we need to work with the hospital. Going on to the next slide, the patient education and instructions engaging in every level, from a primary level to a tertiary level or primordial level, and including them and mentioning that to them about the participation in cardiac rehab at the onset, bring in the values and best practices that will help them in their enrollment and increase that full participation in cardiac rehab. The most important outcomes are, we want to see the end goal, there's wellness, cardiac wellness, and both patient is able to report, I feel much better having gone through this. If not for this, I wouldn't see this. So that's important. And as clinicians or providers, the clinical outcomes that we target, that we want to see in each of these patients. Now, begin cardiac rehab in 1 week after uncomplicated PCI, or in 1 week following a CABG, which is uncomplicated, or transcatheter, or 1 to 3 weeks for those who need a little extra time to recover. Overall, in 2 to 6 weeks for someone who had complex cardiac surgery or a procedure who were requiring prolonged rest, in 2 to 6 weeks. Even those patients going to acute care rehab or a facility, they need to be referred at the beginning. All right. Now, what is the burden? The burden and the availability of cardiac rehab across the globe. We see the shades that are in the high are the ones which there are folks that are cardiac rehab by the countries with economically developed. There is more availability of cardiac rehab, and then lower for those who have economically not there to provide support such programs. In the U.S., the yellow dots are the hospitals that are listed with the cardiac rehabilitation centers. And the next few slides are graphs on the use of cardiac rehabilitation. Here you will see similar presentations with many other presenters who will talk about the use. This particular graph map shows about the eligible patients per 1,000 beneficiaries. This particular slide talks about the rate of participation. As you see, compared from the previous graph to the previous map to this, the rate of participation declines, and the rate of completion of 36 sessions or more further declines. So it's important that we are tasked with encouraging patients at the acute care setting to engage with full participation. In the previous talk, Dr. Thomas mentioned about the healthcare effectiveness data on number of eligible patients. Here we have about 412,000, and initiation, engagement, and completion of their sessions, achievement of the sessions, we have close to about 21 to 25%. So there's work to do. So what do folks at the acute care setting have to do? Referral is key to unlock early enrollment and participation. That's our job. That's the direct job for us who see an eligible patient at the acute care settings. Now, why should we do that? It's based on evidence. One, again, this is published by Dr. Thomas and team. That means level 1, the class A, 1A means strongly recommended. It's a high level of evidence, should be recommended. It's indicated, it's useful, effective, and beneficial. So therefore, we need to promote that. Now, when we do such processes, we want to make sure there is value that is defined by the patient. It's individualized, as I mentioned earlier, both social and clinical health determinants. And it's a value to the clinician and provider, the process that's involved. Value to the whole team in doing this, the whole process, care coordination, and the centers receiving such referrals should find value in the process. So this is totally important to drive this by value. Now, this is by the what is the best practice here? We want to refer all eligible patients before they discharge from the clinic or the hospital, because it's evidence 1, and it should be a team-based approach, not just one person or a group of people in the cardiovascular setting doing it. It's everyone hands-on on this process. So I bring this slide up. So what's transformation here? This is a blueprint. Refer patients in your settings before hospital or clinic discharge. enroll them in 21 days, ensure they could enroll them in 21 days soon after the hospital discharge. Encourage them to participate fully in 36 or 72 sessions. At home, our journey began with, on the inpatient side, we were not there when we started. We started with the word of mouth. We were paper-based. We went on to electronically routing, partially paper, and then we went into fully automated referrals. So that's a fishbone showing cause and effect, and this could be similar with many other folks in cardiac rehabilitation in the hospital setting trying to promote referrals. Now, I did evidence-based search, looked at 7 databases and gathered about 1,235 literature looking at the referral process and methods, and appraised about 46 of them and looked at their, this is the map showing which countries had the referral process and methods, about 46 in total. And this is the levels of evidence, about 3 systematic reviews and about 25 of them in the level 4 cohort study. And overall, in summary, about 52% of them were automated. And we saw that about in our poll today, about close to 38% or more. So many folks, many of us are in the process, are on the journey of automating the referrals. Now, while we were on to automation, it took long. I mean, each of our journeys are different. And to bridge that gap while we're waiting on automation, we did a nurse-led process, used a triangulation transitional care model where we involved the point of care providers, PCP, cardiologists, and the cardiac rehabilitation centers or secondary prevention centers to say, hey, here is a patient who's eligible. Make sure you get him into the cardiac rehab. And we did that right before, soon after the procedure or an event or right after our consults. Made sure it's before they left the hospital in the inpatient setting. And then we disseminated this process by a poster, shared what we were able to do. And overall, the outcomes were in the myocardial infarction, PCI, CABG, heart valve repair and replacement. We started at 3.7%, and then in the last 2 years, we are averaging about 99%. And with heart failure population, less than ejection fraction, less than 40%, in the last 2 years, they're about 95% in the referral. And then we established the automated cardiac rehab referrals, engaging the point of care providers, which I mentioned, and also at the outpatient setting. So that's the summary of our efforts. So what's the take-home message? What's the advocacy for transformation? All eligible patients should be referred. Engage them early, send referrals early, and before the patient leaves the hospital or clinic. There is no waiting period. So let's remember this. The reason for a patient not being able to join cardiac rehab right away after hospital discharge is quite different from not being able to send a referral. We may not be able to send a referral when a patient declines, no, I don't want to participate, or a patient is deceased. Otherwise, there's no waiting period. So referrals are best achieved through automation. So this means timely referral. Every day we wait, there's one person less likely to start cardiac rehab. So therefore, avoid any delays to enhance enrollment and participation. Prevent harm by engaging in early secondary prevention strategies. Are we there yet? So for many of us, not so, or we're still continuing the journey. So we are tasked with addressing the variations, removing the barriers, and helping us reach to these 3 pillars: referral, enrollment, and full participation. That I end and I yield back for questions. I'm going to have the Q&A at the last. I'm going to have Mario, if you could help us cue the video for Julie Arbuckle. Julie Arbuckle is one of our nurse managers at the local Mountain View Cardiac El Camino Health. She is the manager, and she's a exercise nurse and exercise physiologist who works with the team there, both cardiovascular and pulmonary rehabilitation.
Good morning and welcome. My name is Julie Arbuckle, and I'm the clinical manager of the Cardiac and Pulmonary Wellness Center at El Camino Hospital in Mountain View, California. I've been asked to speak this morning on phase 2 hospital-based cardiac rehab. So we are a nationally certified program. We offer a 12-week program or 36 sessions. It is a monitored program and it's covered by insurance, which includes both Medicare and private insurances. So here at El Camino, we meet Mondays, Wednesdays, and Fridays for an hour of exercise. And on Wednesdays, we have Wellness Wednesdays, so they will stay for an hour of education. So over the years, we have figured out it's not just what you do with your feet, but it's also what you do with your fork and what you do with your feelings. So we have an extensive food as medicine program that is run by our full-time dietitian, where she teaches our patients about plant-strong eating. She will do food demonstrations and the patients are actually able to taste. We do know that what you put into your system has a strong correlation with cardiovascular health. Then we have a Stress Matters educational program, and that's run by one of our nurses that was certified in the Bob Stahl Mindful Meditation Program. So she works with our patients on identifying stressors and ways of reducing overall stress. And then we also have our risk reduction lectures that are cholesterol, medications, exercise physiology, and we also do a class on prediabetes. So each of our patients that come through our program get an individualized treatment plan. It starts with an extensive intake phone interview where we go over their medical history, we look at their medications, we help them identify measurable goals that they hope to complete by the program's end. They also come to a group orientation prior to starting the program. They're introduced to our medical director. They're given an overview of the program. They have some surveys to fill out, and then they're given a physical assessment test, which usually is the 6-minute walk test. If they're a patient that is high fall risk, then they will do a submaximal new step test on their first day of class. While the patients are in the program, every 30 days, they have a one-to-one with one of our staff members to reassess and review their initial goals and to give them their progress. That individualized treatment plan is then updated. It's sent to the medical director and he signs off on it. And that is a CMS requirement. So how does a patient get to cardiac rehab? First, they have to have a qualifying diagnosis. And as you can see, I've listed them on the top of the screen. Here at El Camino Hospital, we have a standard discharge order for cardiac rehab. So any of our patients that fit one of these qualifying diagnoses, they are automatically sent an auto-generated referral. Then we get the auto-generated referrals from Stanford Hospital when they discharge their patients. So if their patients are in our community, then they'll send us a referral. And then of course we have the paper referrals that come from individual cardiologists. And you can see Pam Sutter, Stanford Clinics, Kaiser Heart Failure, and other private offices. We like to call our patients within 4 to 6 weeks of discharge to get them started. Once our patients have gone through the program, we always want to set up a transition program because we know it's not just what they've done in this 12 weeks with us, but how are they going to sustain this for a lifetime? We have a community partnership with the YMCA where our patients are given a 60-day free membership, and if they decide to join, then the initiation fee is waived. We also give them a list of local senior centers, and then if they feel like they still want a little bit more supervision, we can refer them out to a community-based cardiac rehab, phase 3 maintenance, and Heart Fit for Life has a great one. So the shout out for cardiac rehab, why is it so important? We know that the emotional and physical recovery of patients that go through cardiac rehab are far better than those who don't attend. They're less likely to be depressed. They realize they aren't alone. There's others going through similar or often the same things. It builds a sense of self-confidence. Education on lifestyle management will help them throughout their lifetime. They're also less likely to be readmitted to the hospital, and they're 40% less likely to have a recurrent event. So that's it for me. You can see my contact information. Please feel free to call or email me with questions or comments. Thank you.